Welcome to the Deep Dive. Today, we're really getting into the weeds on global maternal and perinatal health. It's a huge topic.
It really is.
And our mission today, well, it's ambitious. We want to master the entire framework. The epidemiology, the metrics, how the global goals have evolved.
And crucially, the policies needed, the things that actually make a difference on the ground.
Exactly. We're aiming for that professional level understanding, going beyond just the surface numbers.
And it's a field that really sits at a fascinating crossroads, doesn't it? You've got medicine, human rights, politics, all playing a role.
Absolutely. To really grasp where we are now, policy-wise, we need to look back, right? Where did this global push start?
It really formalized back in 1987. The World Health Organization, the WHO, held this key conference in Nairobi, Kenya.
The birthplace of the Safe Motherhood Initiative, SMI.
That's the one, the Safe Motherhood Initiative. It really kicked things off.
And they set a pretty high bar from the start, didn't they, that initial goal?
Hugely ambitious. They aimed to cut maternal deaths by at least half by the year 2000.
Which, spoiler alert, didn't quite happen in that time frame.
No, it proved much tougher. So the timeline got extended, and that effort eventually fed into the Millennium Development Goals, the MDGs, which took us up to around 2015.
But the core strategy they laid out back in '87, that's still relevant, isn't it? It wasn't just about building hospitals.
Not at all. That's key. It was about improving the quality and safety of life for girls and women, using both health strategies and non-health strategies.
That distinction feels critical for mastering this topic. Health versus non-health.
It reframes the whole thing. It takes it from being purely a medical problem to, well, a deeply social one, too.
Our sources mention social obstetrics. Can you unpack that a bit?
Yeah, it's about providing care not in isolation, but considering the whole context. The community's social situation, economic factors, environment, culture, everything.
So you're acknowledging that a woman's health, her outcomes, are tied directly to her status in society.
Precisely. It's fundamental to understanding the disparities we see.
Okay, let's start laying the groundwork then. The metrics. If we want mastery, we need precision. First up, maternal death. What's the strict definition?
Okay, the definition is very specific, which is important for tracking trends accurately. Maternal death is defined as the death of a woman while she's pregnant, or within 42 days after the pregnancy ends.
42 days. That's 6 weeks.
Exactly. And it doesn't matter how long the pregnancy lasted or where it was located, say, ectopic.
But the cause is the crucial part.
Absolutely critical. The death has to be from a cause that's related to the pregnancy or aggravated by the pregnancy or how it was managed.
Okay, so related to or aggravated by, what does it exclude then? That seems just as important for clarity.
It specifically excludes accidental or incidental causes.
Like a car crash.
Exactly. If a pregnant woman tragically dies in a car accident, or maybe from something like typhoid fever that's totally unrelated to her being pregnant, that's not counted as a maternal death in these statistics.
It has to be linked directly to the reproductive process or the care around it.
Correct. That's the boundary. Hashtag tag 1.1 defining maternal mortality.
Right. Now, the numbers used to quantify this. People often mix up the ratio and the rate. Let's clarify the main one, the maternal mortality ratio, or MMR. That's the standard, isn't it?
It is. The MMR is the number of maternal deaths for every 100,000 live births.
Per 100,000 live births. So it's tied directly to the outcome of pregnancy.
Yes, it gives you a sense of the risk associated with each birth. Basically, how dangerous is it to go through childbirth in a particular place or time?
Okay, so that's the MMR. Why do we also have a maternal mortality rate then? What does that tell us differently?
The maternal mortality rate looks at it from a slightly different angle. It uses a wider population base.
Also,
It measures maternal deaths per 100,000 women of reproductive age, typically defined as women aged 15 to 49 within a given year.
so it's not tied just to live births, but to the whole population of women who could become pregnant.
Exactly. It gives you a sense of the overall burden of maternal death on that age group and the population over time.
And the source material gives a pretty stark example using this rate, comparing India and the U.S.
It does. In India, the rate is around 120 deaths per 100,000 women of reproductive age. In the United States, it's about 0.5.
0.5 versus 120. That's a huge difference.
It really highlights the vast gap in safety nets and healthcare systems.
And just to complete the terminology, there's also reproductive mortality.
Yes, that's an even broader term. It includes maternal mortality deaths related to pregnancy and childbirth, but it also includes deaths resulting from contraceptive use.
Okay, so it captures a wider spectrum of risks related to reproduction.
Right, the full picture,
Mm.
hashtag 1.2, the global disparity and magnitude.
Let's talk scale now. Using the MMR, that standard measure, what did the global picture look like around 2015 when the MDGs wrapped up?
The estimate then was around 303,000 maternal deaths globally. Across 183 countries studied, that worked out to a global average MMR of 216 per 100,000 live births.
216 globally. But as you said, that average hides the real story, which is the massive disparity.
It absolutely does. And this disparity is really the crux of the policy challenge. If you look at developed regions, the MMR is incredibly low.
How low?
The average is about 12 per 100,000 live births, usually falls somewhere between 11 and 14. Very consistent, very low.
Okay, 12. Now contrast that with developing regions.
It's a completely different world. The overall MMR in developing regions averages 239 per 100,000 live births.
So roughly 20 times higher than the developed region average.
About 20 times higher on average, yes. But even that average hides huge variation within developing regions. The range goes from maybe 27 in some places, all the way up to a shocking 546 in others.
Wow. 546. That's almost unimaginable.
It is. And here's the kicker. Those developing regions, they account for 99% of all estimated maternal deaths worldwide.
99%.
99%. It underscores that this is overwhelmingly a crisis of poverty and inequity, not just a medical issue spread evenly.
I think the lifetime risk statistic makes that disparity even clearer. It's quite powerful.
It really brings it home. Think about it this way. For a woman living in a developing region, her lifetime probability of dying from a pregnancy-related complication is roughly 1 in 150.
1 in 150.
Okay?
And in a developed region?
The risk plummets. It's about 1 in 4,900.
1 in 4,900 compared to 1 in 150.
The difference is staggering, and our source material rightly points out this isn't just bad luck. It reflects a huge difference in national commitment. It's about priorities, resources, systems.
We even see this variation playing out within a single large country, like India. You mentioned their rate earlier.
Yes, India's made progress. The national MMR dropped from 178 in the 2010-2012 period to 130 in 2014-2016. Their lifetime risk is now about 0.3%.
Still progress needed, but moving in the right direction. But the variation within India is key.
Absolutely key. It shows what's possible with focused effort. You have states like Kerala with an MMR down at 46, Maharashtra around 61. These are approaching developed country levels in some ways.
But then you contrast that with
states like Rajasthan, which reported an MMR of 199 in the same period, much higher than the national average.
So even with the same national policies, the local implementation, the infrastructure, the access, that makes all the difference.
It's everything. Governance, reliable services, and whether women can actually use those services. Hashtag 1.3 classification and factors.
Okay, so we know the scale and the disparity. To figure out how to intervene, we need to know why women are dying. The classifications help focus efforts, right? Direct, indirect, and non-obstetric. Let's break those down.
Right. The biggest category by far is direct obstetric deaths. These account for about 75%, 3/4 of all maternal deaths.
And these are deaths resulting directly from
complications that happen during the pregnancy itself, during labor or delivery, or from the management or mismanagement of those complications.
So things like severe bleeding.
Exactly. Hemorrhage is a huge one. Also, conditions like preeclampsia and eclampsia, infections after childbirth, puerperal sepsis complications from unsafe abortions, or an ectopic pregnancy rupturing.
It's interesting that suicide is included here as a direct death. Why is that?
It's a recognition of the immense psychological toll pregnancy and the postpartum period can take. When suicide occurs during this time, it's often linked directly to severe conditions like postpartum depression or psychosis, which are themselves complications related to the pregnancy or its aftermath. So it's considered directly attributable.
Okay, that makes sense. So if direct deaths are 75%, what makes up the other 25%? Mostly indirect deaths.
Mostly, yes.
Yeah.
Indirect deaths account for that remaining quarter. These happen when a woman has a pre-existing medical condition.
Like heart disease.
Like heart disease or maybe diabetes or severe anemia. The pregnancy itself doesn't cause the condition, but the physiological stress of being pregnant aggravates it to the point where it becomes fatal.
The pregnancy pushes an underlying vulnerability over the edge.
Precisely.
And the sources single out one indirect cause as being particularly important in developing countries.
Anemia. Severe anemia is incredibly prevalent, and it drastically reduces a woman's ability to survive even moderate blood loss during childbirth. It makes hemorrhage, a direct cause, far more deadly.
So it acts like a multiplier for other risks.
A very dangerous one. And finally, there's the small category of non-obstetric or fortuitous deaths, those completely unrelated accidents or infections we mentioned earlier, like dying in that car crash.
Got it. Beyond the clinical cause, there are factors that make certain women more vulnerable. Age and parity seem crucial.
Very much so. The general consensus is that the safest time for childbirth, biologically, is between 20 and 25 years old.
Risks increase outside that window.
Significantly. Very young adolescents, say under 18, face higher risks. Their bodies might not be fully mature, leading to complications like preeclampsia or cephalopelvic disproportion, where the baby's head is too big for the mother's pelvis, or problems with the uterus contracting effectively during labor.
And older mothers.
The risk climbs again quite steeply for women aged 35 and older. Their risk of maternal death can be 3 to 4 times higher than for women in their 20s.
And parity the number of previous births.
Also a major factor. The lowest risk is typically for the second pregnancy, but once a woman has had 5 or more pregnancies, what we call grand multiparity or para 5, and above the risk jumps up again, about 3 times greater.
Why is that?
Increased risk of things like postpartum hemorrhage, the baby being in an unusual position, malpresentation, and in very rare, tragic cases, uterine rupture. The uterus has just been through a lot.
And all of this is layered on top of socioeconomic factors.
Always. It's almost a universal finding. Maternal mortality is higher in lower socioeconomic groups.
Why specifically? Lack of access.
Lack of access is huge, but also poorer nutrition, less education about warning signs, less power to make decisions about seeking care, and the care they do access might be substandard.
What does substandard care mean in this context? It's not just about individual mistakes, is it?
No, it's often systemic. It could be a lack of essential resources like blood for transfusions or not enough trained staff. It could be the absence of basic backup facilities like a functioning laboratory to run crucial tests. The system itself fails them.
Which brings us right back to that idea of the social dimension.
Exactly. The expert consensus from WHO to human rights groups is that maternal death isn't just a health statistic, it's a marker of social disadvantage.
A reflection of women's status in society.
Fundamentally, low social status for girls and women is seen as a root cause of high maternal mortality, especially in developing countries. It's about gender inequality.
How does that inequality translate into actual barriers to safe motherhood?
It plays out in so many ways. Limited control over money, fewer educational opportunities, often heavier workloads combined with poor diets, and critically, less autonomy, less power to decide when and if to have children or when to seek health care.
So they might delay seeking care.
Or not seek it at all until it's an absolute emergency. This lack of agency often leads to unplanned, high-risk pregnancies and deaths that could have been prevented if they'd had access to timely, respectful care. The link between social status and clinical outcome is undeniable.
Okay, we've mapped the problem, the scale, the disparities, the social drivers. Now let's get practical. Let's talk solutions. What are the primary clinical reasons women die, and what actually works to stop these deaths?
If we focus on developing regions where the burden is highest, the picture is quite clear. You can think of maybe the 4 main killers.
The 4 horsemen of maternal mortality.
Something like that, they are. Hemorrhage, sepsis, or severe infection, hypertensive disorders like preeclampsia and eclampsia, and the consequences of unsafe abortion.
And tackling those 4?
If you can effectively prevent and manage those 4 conditions, you could eliminate potentially 80% of preventable maternal deaths. It's a huge impact.
The focus might shift slightly in highly developed countries.
Yes, the order might change slightly. Hypertensive disorders, hemorrhage, and maybe pulmonary embolism might be more prominent. But in resource-limited settings, those first 4 are absolutely the priority targets. Hashtag tag 2.1 core clinical causes and proportionality.
Let's break them down using the percentages from the source material to see the scale. Hemorrhage comes first.
Hemorrhage is the single biggest direct cause, responsible for about 20 to 25% of deaths.
And that's mostly bleeding after birth.
Mostly, yes. Postpartum hemorrhage, or PPH, bleeding before birth, Antepartum hemorrhage, things like placental abruption or placenta previa, are dangerous too, but PPH is the major killer. It can be sudden, massive blood loss.
And deadly fast, especially if the woman is already anemic.
Exactly. A healthy woman can die within hours, an anemic woman even faster.
So what are the proven interventions? What actually works against PPH?
It's a combination of preventative public health and rapid response. First, addressing anemia during pregnancy is vital, building up iron reserves.
Makes sense. Build resilience.
Then, during the delivery itself, having a skilled birth attendant, an SBA, is crucial for what's called active management of the third stage of labor.
That's managing the delivery of the placenta.
Yes, and using drugs called oxytocics, like oxytocin, proactively to help the uterus contract strongly and clamp down blood vessels. That prevents excessive bleeding.
And if bleeding still happens,
Then, immediate action is needed. Rapid fluid replacement to maintain blood pressure, and having access to safe blood for transfusion is absolutely non-negotiable in severe cases.
okay, hemorrhage number 1, what's next? Infection or sepsis?
Sepsis accounts for about 15 to 20% of deaths. This is severe infection, usually occurring during labor or in the days after birth, the puerperium.
What triggers it?
Often things like membranes rupturing early, prolonged, or obstructed labor, which increases exposure, or unhygienic delivery practices.
So the interventions are focused on cleanliness and drugs.
Primarily, again, skilled attendants are key. They need to practice meticulous hygiene. The 3 cleans are a simple but vital concept.
3 cleans.
Clean hands of the attendant, a clean delivery surface or perineal area, and clean cutting and care of the umbilical cord. Simple steps that drastically reduce infection risk.
And if infection is suspected?
Then prompt diagnosis and timely administration of appropriate antibiotics are life-saving. Delay is dangerous.
Got it. Third on the list, hypertensive disorders, preeclampsia and eclampsia.
Yeah.
About 12 to 15%.
Yes. This is high blood pressure during pregnancy that can affect multiple organs and, in the case of eclampsia, lead to life-threatening seizures.
It'd be managed.
It absolutely can, but it requires vigilance. The key interventions are early detection through regular antenatal care, checking blood pressure and urine protein at every visit.
And if it's detected?
Appropriate referral to a facility that can manage it is crucial. And the definitive life-saving treatment, especially for preventing or controlling eclamptic seizures, is magnesium sulfate, MgSO4.
Magnesium sulfate. That's a critical drug.
Incredibly critical. Having it available and having staff trained to use it correctly is a basic measure of quality obstetric care.
Okay. The fourth major cause, unsafe abortion. Around 10 to 13%. This one feels directly linked to policy failures.
It absolutely is. The deaths here result from abortions performed by untrained individuals in unhygienic conditions or self-induced.
So the interventions are broader than just clinical treatment.
Yes, prevention is key. This means ensuring women have access to comprehensive family planning services so they can avoid unwanted pregnancies in the first place.
And if prevention fails,
Then, access to safe, legal abortion services is crucial to prevent women from resorting to dangerous alternatives. Where complications from unsafe abortion do occur, prompt treatment by a skilled provider is needed, usually evacuating the uterus, treating infection with antibiotics, and managing hemorrhage. Comprehensive post-abortion care is essential.
there's one more direct cause listed with a significant percentage. Obstructed labor. About 8%.
Right. This is when the labor just doesn't progress because the baby physically can't pass through the birth canal.
Why would that happen?
Could be cephalopelvic disproportion, the baby's head is too big, or the mother's pelvis too small, or the baby might be in an abnormal position, like sideways, transverse lie, or breech.
What's the intervention here? How do you know it's happening?
The key tool is the partograph. It's a simple chart used to track the progress of labor's cervical dilation, descent of the baby's head, plotted against time.
So you can see if things stall.
Exactly. If the progress line flattens or crosses certain alert lines on the partograph, it signals potential obstruction. That's the trigger for timely referral to a facility that can perform an operative delivery, usually a cesarean section.
Acting early is critical.
Critical. Delay can lead to uterine rupture, fistula formation, infection, and death for both mother and baby.
And finally, let's loop back to anemia. It's listed as an indirect cause, but its impact seems huge, contributing to 15–20% of deaths.
Its impact is pervasive. As we said, it weakens women, making them less able to withstand hemorrhage or infection. Globally, maybe half of all pregnant women are anemic.
Mostly due to diet.
Primarily poor diet lacking iron, yes, but also chronic infections that deplete iron stores, like hookworm, malaria, or even HIV.
So the interventions are basic public health measures.
Staples of good antenatal care. Routine supplementation with iron and folic acid, IFA, ideally daily for at least 100 days during pregnancy and postpartum, plus treating those underlying infections prevalent in the community. Deworming, malaria prevention and treatment, HIV screening and management, it's all part of protecting mothers. Hashtag TAG 2.2, the role of systems and policy.
It's crystal clear that having the right clinical interventions isn't enough if the system doesn't support them. Our sources list so many contributing social factors in developing countries: illiteracy, teenage marriage, lack of knowledge, high fertility rates, poverty. How does the health system start to tackle these deeper issues?
It requires a massive coordinated effort. It's not just the Ministry of Health. It involves the family, the community, the entire health system, from local clinics to hospitals, and crucially, the government through legislation and policy.
It has to be a national priority.
Absolutely. It needs high-level political commitment backed up by real budgets and laws that support women's health and rights. It needs to be a long-term vision, not just short-term projects.
Okay, let's focus on the specific actions the health sector needs to take. What are the non-negotiables for a system designed to reduce maternal deaths?
3 things stand out. First, ongoing risk assessment. Identifying women at higher risk early in pregnancy and providing them with tailored care.
Second,
Ensuring a skilled birth attendant, that SBA we talked about, is present at every single birth. That's the goal.
ambitious but essential. And third,
A functioning referral system. There has to be a clear, reliable pathway to get a woman from her home or a basic clinic to a higher level facility quickly if complications arise. This includes transport and communication.
and that referral system needs to lead somewhere capable. You mentioned the first referral unit, the FRU. This seems like a critical bottleneck, especially in rural areas. What absolutely must an FRU be able to do to provide effective emergency obstetric care, or EMOC?
The FRU is where the system proves itself. It's not enough to just have a building. It must have the capacity for blood transfusion safe, screened blood available 24/7.
That's number one.
Number 1. It must also have the facilities and staff to perform surgery, specifically laparotomy, opening the abdomen, and, most critically, cesarean sections around the clock.
247 surgical capacity.
Without surgery and blood, it's not truly a functional FRU capable of handling life-threatening emergencies. It's a missing link.
Okay, those are the health system actions. What about the broader policy actions? These seem to push into changing societal structures.
They absolutely do. This is where we address the root causes embedded in inequality. The policy requirements include things like,
Removing barriers.
yes, removing all barriers, financial, geographical, informational, that stop women from accessing the care they need.
Empowering women.
Increasing women's decision-making power over their own bodies and health, their reproductive choices, their healthcare choices, ensuring true autonomy.
What about abortion policy?
Guaranteeing access to safe abortion services and quality post-abortion care through national laws and policies is explicitly mentioned as crucial.
And tackling discrimination.
Yes, actively working to eliminate all forms of social inequality and discrimination, whether based on gender, age, marital status, ethnicity, or anything else that prevent women from getting equitable care. These aren't just nice-to-haves, they are fundamental prerequisites for saving lives.
So you have all these different pieces: clinical care, systems, policy. How do you bring it all together? We need a framework. The sources mentioned the reproductive and child health, or RCH, care model, especially in India, as an example. What's the big idea behind RCH?
RCH is really about integration. It aims to provide a comprehensive package of services for women's and children's health, breaking down the silos between different programs.
So not just focusing on pregnancy, but the whole life cycle.
Exactly. It's designed as a composite approach, bringing together maternal health, child survival, adolescent health, family planning, and management of reproductive tract infections under one umbrella.
And it involves multiple players.
Yes, it typically relies on strong government leadership in India through the National Health Mission, NHM, and aligning with the National Population Policy, NPP, but also crucial support from international partners like the World Bank and WHO. It's a collaborative effort.
What were the later phases of RCH focusing on, and making it operational?
Yes, RCH Phase 2, for instance, put a lot of emphasis on actually delivering the services, upgrading facilities to provide that comprehensive emergency obstetric care, EMOC, at the FRU level, and empowering those skilled birth attendants with the necessary skills, drugs, and authority. Hashtag 3.1 reproductive and child health RCH care.
Let's drill down into the specific safe motherhood measures within an RCH framework. How does it structure care across the pregnancy journey, starting with antenatal care, ANC?
ANC is all about prevention and early detection. The RCH guidelines emphasize early registration, getting women into the system ideally within the first 12 weeks of pregnancy.
And regular checkups.
Yes, a minimum number of visits is recommended. The WHO standard is at least 4 visits, though some national guidelines, like India's, might focus on ensuring at least 3 quality visits covering all essential components.
What happens at these visits?
Screening for risks, checking blood pressure, testing urine for protein to detect preeclampsia, screening for anemia. It also includes essential preventative measures like giving tetanus toxoid immunizations.
And tackling anemia.
Absolutely central. Daily iron and folic acid IFA supplementation is standard typically for at least 100 days, starting after the first trimester, and often continued postpartum.
Okay, that's ANC. What about intranatal care, the care during birth itself?
The big focus here is shifting births out of unsafe home environments and into facilities. The target is often ambitious, like aiming for 80% institutional deliveries.
And ensuring skilled help is present.
Yes, the ultimate goal is 100% of deliveries attended by skilled personnel doctors, midwives, nurses trained in SBA competencies. And during the birth, maintaining those 3 CLINs we talked about is paramount to prevent infection for both mother and baby.
Reducing sepsis and neonatal tetanus.
Exactly.
Then comes postnatal care, PNC. This period is often overlooked, but seems critical.
Hugely critical. The first few days and weeks after birth are high risk for both mother and baby. PNC involves checking the mother for complications like bleeding or infection, supporting her recovery.
And for the baby.
Monitoring the newborn's health, checking for danger signs, promoting warmth and feeding.
It's also a key time for other services.
Yes, PNC visits are a crucial opportunity to provide family planning, counseling, and methods, allowing women to space their next pregnancy safely. It's also when you reinforce messages about exclusive breastfeeding and ensure access to any follow-up care needed, including safe abortion services if complications arise related to the recent birth.
The whole system seems to hinge on that skilled birth attendant, the SBA. Yeah. Let's be really clear on who this person is and what makes them skilled.
Right. An SBA isn't just anyone who helps at a birth. It's an accredited health professional, could be a midwife, a doctor, or a nurse who has undergone specific training and demonstrated competency in a set list of skills.
What skills are key?
They need to manage a normal, uncomplicated pregnancy, labor, and the immediate postpartum period effectively. But just as importantly, they need the skills to recognize complications when they arise.
The diagnosis is critical.
Diagnosis and initial management. They need to know the warning signs, make a timely decision that things aren't normal, provide essential first aid, and then crucially organize referral efficiently to a higher level of care. They are the gatekeepers to EMOC.
To make that role effective, especially in remote areas, they need tools. The sources list specific life-saving drugs SBAs are authorized to use. This seems like a vital policy decision.
It's a game changer because it reduces delays in treatment. Giving SBAs the authority to administer certain essential drugs at the community level or in basic clinics can be life-saving.
What drugs are we talking about?
For preventing PPH, they can often use misoprostol tablets. For treating PPH, they're authorized to give injectable oxytocin.
And for eclampsia?
Injectable magnesium sulfate, MgSO4. Being able to give that first dose before referral can prevent seizures and death.
And infections?
They can typically administer essential antibiotics like ampicillin or metronidazole to start treating suspected sepsis while arranging transfer.
They're also allowed certain procedures.
Yes, depending on their specific training and the local protocols, they might be trained in things like active management of the 3rd stage of labor, using the partograph, and sometimes even basic interventions like manual removal of remaining placental tissue in case of incomplete abortion if bleeding is severe and referral delayed.
Let's revisit Comprehensive Emergency Obstetric Care, EMOC, at the FRU level. We covered the need for blood and C-sections. What other key components make it comprehensive?
Beyond blood and surgery, a comprehensive EMOC facility needs a reliable anesthetic service available 24/7. It needs the capability for assisted vaginal delivery, like using a vacuum extractor.
How else?
Manual removal of the placenta if it doesn't deliver normally. Access to safe abortion services and management of complications. And importantly, providing contraceptive services, including sterilization, for women who desire it postpartum or post-abortion.
And the system needs to connect women to these facilities. You mentioned transport links. What about the community connection?
That's where community health workers become vital. In India, the accredited social health activist, or ASHA, is a key example under the National Health Mission.
What's the ASHA's role?
The ASHA is often a local woman who acts as the bridge between the community and the health system. She encourages women to register for antenatal care, promotes institutional delivery, accompanies women to the facility, provides basic health information.
And links them to programs.
Yes, like the Janani Shishu Suraksha Karyakram, JSSK, which provides incentives and free services for delivery and newborn care. IASHAs help women navigate the system and overcome barriers to actually using the services that are theoretically available. Without that link, the best facilities can remain underutilized.
We've focused heavily on preventing death, which is obviously paramount. But survival isn't the only measure of success. What about the women who survive severe complications but are left with lasting health problems? Let's talk about maternal near miss and morbidity.
This is such an important area and increasingly recognized. Focusing only on deaths misses a huge part of the picture, the suffering and long-term consequences for survivors.
So what is a maternal near miss, or MNM, sometimes called severe acute maternal morbidity, or SAM?
The WHO defines it as a woman who nearly died but survived, a complication that occurred during pregnancy, childbirth, or within those 42 days postpartum.
Why track these near misses? What do they tell us?
They provide incredibly valuable insights into the quality of care. They show us where the system succeeded in pulling someone back from the brink, but also highlight the severity of the complications occurring. Studying near misses helps identify weaknesses and improve care before they lead to deaths.
How do we measure how often near misses happen?
We use the maternal near-miss incidence ratio, or MNMR. That's the number of MNM cases per 1,000 live births.
What kinds of conditions typically lead to a near miss?
Often the same conditions that cause death, just managed successfully in time. Things like severe preeclampsia or eclampsia, massive postpartum hemorrhage requiring large transfusions, acute kidney failure, severe sepsis leading to shock, or clotting disorders like disseminated intravascular coagulation, DIC.
How is a case formally diagnosed as a near miss? Is there a strict criteria?
Yes. The WHO has established criteria based on signs of organ dysfunction. It's quite detailed.
Yeah.
A woman generally needs to meet criteria indicating severe problems in multiple areas.
Can you give examples?
Okay, there are three main categories: clinical signs, laboratory investigations, and interventions needed. You usually need to meet criteria from all three, or experience a cardiorespiratory collapse.
So clinical signs might be
Things like severe low urine output oliguria, less than 30 millimolars per hour, indicating kidney failure, or signs of shock, like very low blood pressure, or neurological signs like coma or prolonged unconsciousness.
and investigations, lab results.
Yes. For example, very low oxygen saturation levels, SpO2, below 90%, indicating severe respiratory problems, or lab tests showing severe liver dysfunction, kidney failure markers, or critical abnormalities in blood clotting.
And the third category, interventions.
This reflects the level of care needed to save her life. Things like needing admission to an intensive care unit, ICU, requiring mechanical ventilation, undergoing emergency surgery to stop bleeding, like a hysterectomy, or needing a massive blood transfusion. The threshold is often set at more than 5 units of blood.
So surviving despite needing these extreme measures qualifies as a near miss.
Essentially, yes. It signifies she was critically ill due to the pregnancy complication.
And the scale of morbidity beyond near misses is vast, isn't it?
It's huge and often hidden. The estimate is that for every woman who dies, at least 15 more suffer serious, often long-term health problems as a result of pregnancy or childbirth.
15 to 1.
Yes, that translates to millions of women globally. The source suggests 5 to 7 million women annually whose quality of life is significantly impaired by these morbidities.
And some of these problems are permanent, life-altering disabilities. What are the major examples?
The obstetric fistulas are probably the most devastating socially and physically. Vesicovaginal fistula, VVF, where there's a hole between the bladder and vagina, and a rectovaginal fistula, RVF, a hole between the rectum and vagina.
Caused by obstructed labor.
Yes, prolonged pressure during obstructed labor cuts off blood supply, causing tissue to die and creating these holes, leading to constant leakage of urine or feces. Other chronic issues include secondary infertility, pelvic organ prolapse, chronic pelvic pain, nerve damage causing paralysis, obstetric palsy, and hormonal problems like Sheehan syndrome.
Sheehan syndrome.
That's damage to the pituitary gland caused by severe blood loss and shock during childbirth, leading to lifelong deficiencies in essential hormones. These aren't just minor issues, they profoundly affect women's lives. Hashtag tag 4.2 perinatal mortality, PNM. Now, shifting focus slightly from the mother's morbidity to the outcome for the baby around the time of birth, we need to look at perinatal mortality, or PNM.
This is seen as a really sensitive indicator of care quality, isn't it?
Extremely sensitive. PNM rates reflect the quality of both antenatal care and, critically, the care provided during labor and delivery, as well as immediate newborn care. It tells you a lot about the effectiveness of the entire health system.
Let's define it precisely. What period does perinatal cover?
Perinatal mortality includes deaths of fetuses weighing 1,000 grams or more at birth, which roughly corresponds to 28 weeks of gestation that occur before delivery, stillbirths, or during delivery, PLUS deaths of live-born infants within the first 7 days of life, early neonatal deaths.
Okay, so stillbirths plus deaths in the first week. And the rate is calculated how?
It's expressed as the number of perinatal deaths per 1,000 total births, which includes both live births and stillbirths meeting the weight gestation criteria.
You said it reflects care quality. How big is the gap between developed and developing countries here?
It's significant. In most developed countries, the PNM rate is typically below 10 per 1,000 total births. In India, the source quotes a rate around 26 per 1,000. Globally, we're talking about millions of deaths, maybe 4 million newborns dying in the first week, plus around 3 million stillbirths each year.
What factors put a pregnancy at higher risk for perinatal death? Are they similar to maternal risk factors?
Many are overlapping, yes. Poor maternal nutrition is a big one. Extremes of maternal age, very young mothers, or those over 35. High parity, having had many previous births.
In specific medical conditions?
Severe maternal anemia, defined here as hemoglobin below 8 grams per deciliter, is a major risk factor for the baby, too. Obstetric complications are critical. Antepartum hemorrhage, especially placental abruption, is a major cause of stillbirth due to lack of oxygen, accounting for maybe 10% of PNM.
What about hypertension?
Preeclampsia and eclampsia significantly increase perinatal risk, often due to poor placental function leading to growth restriction or the need for preterm delivery to save the mother.
And complications during labor itself?
Absolutely. Difficult or prolonged labor,
Yeah.
dystocia, premature rupture of membranes leading to infection or prematurity, and low birth weight, LBW itself, is a huge risk factor. Babies born under 2 kilograms face a very high chance, maybe 50%, of dying. Hashtag 4.3 stillbirths and neonatal deaths.
To really understand PNM, we need to look at its two main components, stillbirths and neonatal deaths. Let's clarify stillbirth again.
A stillbirth is the birth of a baby after the 28th completed week of pregnancy, or weighing 1,000 grams or more, that shows no signs of life after delivery, no breathing, no heartbeat, no cord pulsation, no movement.
What are the main underlying causes identified for stillbirths?
They often fall into a few key categories. Problems during labor and delivery itself, like birth asphyxia, lack of oxygen, or trauma, account for maybe 30%.
Complications of the pregnancy.
Also around 30%. This includes things like severe placental problems, abruption, uncontrolled maternal diabetes, severe preeclampsia, or infections during pregnancy.
And issues with the fetus itself.
Congenital malformations or chromosomal abnormalities account for about 15%, but it's important to note that in a significant number of cases, maybe 20% or so, the specific cause remains unexplained even after investigation.
Okay, that's stillbirths. What about neonatal death?
Neonatal death is the death of a live-born infant anytime within the first 28 days after birth.
But most happen very early.
The vast majority, yes. Especially within the first 48 hours, and certainly within the first week. That's why those first 7 days, the early neonatal period, are often grouped with stillbirths to calculate the perinatal mortality rate, as the causes are heavily linked to obstetric care.
The sources give a breakdown of the most important causes for overall perinatal mortality. What are the top 3?
The breakdown really highlights where interventions need to focus. Number 1 is infections, things like sepsis, pneumonia, tetanus, accounting for about a third, 33% of perinatal deaths.
Number 2.
Birth asphyxia, lack of oxygen around birth, birth trauma, and also hypothermia, getting too cold, together account for about 28%. These are directly related to the quality of care during delivery and immediately after.
And number 3.
Prematurity and a low birth weight. These often go together and account for roughly 24% of perinatal deaths. Small, preterm babies are just much more vulnerable.
So those three categories, infection, asphyxia, trauma, hypothermia, and preterm LBW, cover the vast majority.
Yes, over 85% of all perinatal deaths fall into those three main groups. It tells us exactly where to target our efforts for maximum impact.
We've covered the definitions, the scale, the causes, the interventions, the morbidities. Let's finish by looking at the big picture policy trajectory. How have the global goals evolved? We mentioned the Millennium Development Goals earlier.
Right. The MDGs ran from roughly 1990 to 2015. Maternal health was MDG 5 and child health MDG 4. The specific target for MDG 5 was extremely ambitious.
The 75% reduction in MMR.
Exactly. A 75% reduction from the 1990 baseline by 2015.
And how did the world do? Did we hit it?
We made significant progress, which shouldn't be downplayed. The global MMR did decline substantially by about 44% overall, down to that 216 figure we mentioned.
But 44% is not 75%.
No. To reach the 75% target, the world needed an average annual rate of reduction of 5.5%. What was actually achieved was closer to 2.3% per year on average.
So progress, but falling short.
Falling significantly short of the target. Only 9 countries actually managed to hit that 75% reduction goal. It really showed that progress wasn't reaching everyone, especially the most vulnerable.
That experience fed into the next set of goals, right? The Sustainable Development Goals, the SDGs.
Correct. Adopted in September 2015, the 2030 Agenda for Sustainable Development brought in 17 interconnected goals. It's a much broader agenda integrating economic, social, and environmental dimensions.
And health has its own goal.
Yes, SDG 3 is dedicated to ensuring healthy lives and promoting well-being for all at all ages. This is where the new targets for maternal and child survival sit, and the ambition level was raised again, hashtag 5.2 SDG targets for 2030.
Okay, let's get specific on those 2030 targets. For maternal mortality, what's the new global goal?
The target for MMR under the SDGs is to reduce the global average to less than 70 maternal deaths per 100,000 live births by 2030.
Less than 70. That's a huge drop from the 216 baseline in 2015.
It requires a significantly accelerated pace of progress. To get there, the world needs an average annual reduction rate of about 7.5%, much faster than what was achieved during the MDG era.
And the targets for newborns and children were also tightened.
Yes. For neonatal mortality, the SDG target is to reduce it to 12 deaths per 1,000 live births in every country.
And for under 5 mortality.
The target is 25 deaths per 1,000 live births globally, again, requiring faster progress than before, aiming to end preventable deaths of newborns and young children.
A core principle underpinning SDG 3 is universal health coverage, UHC. How does that connect specifically to maternal and reproductive health?
UHC is fundamental because it's about ensuring everyone can access the quality health services they need without suffering financial hardship. Target 3.7 within SDG 3 explicitly focuses on this for reproductive health.
What does Target 3.7 call for?
It aims to ensure universal access to sexual and reproductive healthcare services by 2030. This explicitly includes family planning information and education, and integrating reproductive health into national strategies and programs.
So it covers the whole spectrum.
Yes, ensuring access to antenatal care, skilled delivery, postnatal care, contraception, safe abortion, where legal, prevention, and treatment of STIs. The full package, accessible to all. Hashtag 5.3 strategies for ending preventable maternal mortality, EPMM.
To actually achieve these ambitious SDG targets, especially the MMR below 70, the WHO laid out a roadmap, didn't they?
Yeah.
The strategies for ending preventable maternal mortality, or EPMM. What are the key pillars of this strategy?
There are 5 core strategies designed to guide action through 2030. They provide that high-level framework.
Okay, strategy 1.
Strategy 1 hits the equity issue head-on. Address inequities in access to and quality of sexual, reproductive, maternal, and newborn healthcare services.
So tackling those gaps between rich and poor, urban and rural.
Exactly. Recognizing that averages, high disparities, and targeting efforts towards the underserved.
Strategy 2.
Ensure universal health coverage for comprehensive sexual, reproductive, maternal, and newborn healthcare. This reinforces Target 3.7, making sure services are available and affordable for everyone.
Strategy 3 broadens the focus beyond just death.
Yes, it calls to address all causes of maternal mortality, reproductive and maternal morbidities, and related disabilities. This brings in that focus on near miss, on fistula, on the long-term consequences we discussed. It's about health and well-being, not just survival.
Strategies 4 and 5 focus on the system itself.
Right. Strategy 4 is about strengthening health systems to respond to the needs and priorities of women and girls. This means having the right infrastructure, supply chains, information systems, and crucially, a health workforce that is skilled, motivated, and sensitive to gender issues.
And strategy 5.
Ensure accountability to improve quality of care and equity. This is about monitoring progress, using data to drive improvements, ensuring transparency, and making sure governments and providers are held responsible for delivering results.
So if we pull all the threads together from our discussion, the clinical care for complications, the RCH continuum, the system strengthening, the policy changes, what's the essential summary for achieving that SDG target of below 70?
It really comes down to doing all these things simultaneously and effectively. You need excellent clinical management of the major killers like hemorrhage and eclampsia, available 204/7 through skilled personnel and EMOC facilities.
You need strong preventative care.
Absolutely. High-quality RCH care covering antenatal, delivery, and postnatal periods for everyone. You need universal access to contraception to empower women to plan their families and avoid high-risk pregnancies.
And the foundation.
The foundation has to be political will and policy action that tackles poverty, empowers women, removes discrimination, and ensures health systems are funded and function equitably. Experts agree the goal is achievable technically. The barriers are often political and social, not purely medical. #tag outro.
Well, this deep dive really underscores a crucial point, doesn't it? Achieving safe motherhood isn't just a medical puzzle to be solved with better techniques. It is fundamentally a challenge of policy, of social structures, of logistics, and political will.
Absolutely. The evidence is quite compelling. Significant reductions in maternal mortality are possible, sometimes even with relatively limited financial investment, if the policy interventions are smart, targeted, and effectively implemented. Focusing on social determinants and ensuring equitable access to quality emergency care is key.
And that epidemiological comparison we started with just hangs in the air. That lifetime risk, 1 in 150 in developing regions versus 1 in 4,900 in developed regions.
It's more than just a statistic. It's a direct reflection of those differences in political priority and systemic equity, or the lack of it.
So here's a final thought, a provocation for you, our listener, now that you're armed with this detailed understanding. We heard repeatedly about the need to remove social inequalities, discrimination based on gender, age, marital status as being fundamental for health progress.
Think about your own context wherever you are. Even in developed countries, subtle barriers exist. What specific legislative loopholes, cultural norms, or maybe unconscious biases related to gender, age, or marital status might still exist in your community or nation?
How might these seemingly non-health factors still impact women's autonomy, their access to care, or their health outcomes years down the line? That's where social obstetrics becomes essential policy research for everyone. It's about connecting those dots.
Thank you for joining us for this really crucial deep dive into global maternal and perinatal health.
Until next time.